Our lives may be impacted directly or indirectly by myths or legends that we believe in or that other people believe. In this video, I will discuss just a few of the myths and legends that are common around cancer. My name is Dr. David Stewart. I'm a medical oncologist in Ottawa, Canada, and a professor of medicine at the University of Ottawa. And I recently wrote a book called A Short Primer on Why Cancer Still Sucks. It's intended for patients and can be purchased online through Amazon Books if you're interested. This is the 11th out of 16 videos I'm doing on things that people often ask me about cancer. And for additional details, you can see my book. Importantly, for your own personal health, it's very important for you to rely on your healthcare advisors. One popular myth among patients and their families is that one should avoid eating sugar if one has cancer because the sugar will feed the cancer and make it grow faster. But in fact, there's not a lot of evidence to support this. Eating too many calories does increase the risk of developing cancer. And also cancers do use a lot of sugar, a lot of glucose, far more than many normal tissues. But avoiding sugar in the diet is not very likely to help to slow cancer growth. The reason avoiding sugar in the diet is not likely to have a major impact once one already has cancer is because there are immune cells that infiltrate into the cancer and they produce cytokines. So those are proteins that can have an effect on the body. So some of those cytokines like tumor necrosis factor alpha, interleukin 10, and a few others can actually lead to a breakdown of muscle to produce sugar. And this is one of the reasons that patients with cancer lose weight and become weaker is because of this muscle breakdown to produce sugar. So even if you're not eating sugar in your diet, the cancer has lots of sugar because of this breakdown of muscle to produce more sugar. Another myth is that exposing the cancer to air by surgery can make it grow faster. And this arose because patients would undergo surgery and then would deteriorate and die very rapidly after the surgery with very rapid tumor growth. However, this rapid deterioration had little to do with the surgery itself. This arose because before the availability of CAT scans, a surgeon would often not know how much cancer was present before they did the surgery. So the surgeon would open up the patient, find that the cancer was far more extensive than they thought, close them up again, and the patient would continue to deteriorate rapidly and would die shortly afterwards. However, this rapid deterioration was not because the cancer was exposed to air, but just because the cancer was already very extensive at the time that the cancer was first discovered. Having said that, as cancers grow, the rate of growth starts to slow down because there's not enough nutrients to support rapid tumor growth. But if you remove a primary tumor, if there are a whole bunch of small micrometastases, like metastases that are too small to be seen at the time of surgery, and that would show up at a later point in time, if you remove the primary tumor, then that removes competition for nutrients. So those small micrometastases actually may begin to grow faster after either removing the primary tumor or treating it effectively with radiotherapy. If the primary tumor is left in place, it will grow and eventually kill the patient. Whereas if it's removed, the patient may be cured, particularly if there are no small no small metastases in other parts of the body that are too small to be seen at the time of the surgery or radiotherapy. So if adjuvant treatments are given following surgery or radiotherapy, like chemotherapy given after surgery or radiotherapy, then that may kill the small micrometastases and may cure a patient. It is generally better to try to start adjuvant treatments shortly after surgery and not a long time after, because shortly after the micrometastases will still be relatively small. But if you wait, they will be bigger and they will be more difficult to eradicate with the adjuvant treatment. And if there's a delay and the micrometastasis is now growing more rapidly because the primary tumor is removed and there's no more competition for nutrients, then again, it's important to start the adjuvant treatment early rather than waiting. The bottom line is that it's very important to get rid of the primary cancer because you cannot cure a patient unless you do. But you just have to bear in mind that there could be small tumor deposits in other areas that will also need to be eradicated and that could show up at a later point in time if not treated with systemic therapies. The benefit of systemic adjuvant therapies like chemotherapy given after surgery varies across tumor types and also depends on the characteristics of the tumor. but the oncologist will discuss with the patient whether or not they think that adjuvant therapies should be done and whether they might help them or not. One myth that's prevalent among oncologists is that tumors in the brain are protected from systemic therapies like chemotherapy by what is called the blood-brain barrier. The blood-brain barrier is consists of special characteristics of blood vessels in the brain that help decrease the amount of toxins that can escape from the bloodstream into surrounding brain tissue. So this is very, very important for your health, that your brain is protected by this blood-brain barrier. So the blood-brain barrier is very real and very important. But in tumors in the brain, the blood vessels are very abnormal, so that the blood-brain barrier is disrupted within tumors in the brain. That is why brain metastases take up the dye that is given with CAT scans and MRI scans. The dye is taken up because of blood-brain barrier disruption. It's also why there is often evidence of swelling or edema around tumors in the brain, because the blood-brain barrier is abnormal, because it's being disrupted by the formation of abnormal blood vessels within brain metastases. While many oncologists believe that the blood-brain barrier limits penetration of chemotherapy drugs and other systemic therapies into brain metastases, several studies have shown that, in fact, most of these drugs readily penetrate into tumors in the brain, even if they reach only very low concentrations in normal brain and the cerebrospinal fluid, which is the fluid that bathes the brain. Even very large molecules like monoclonal antibodies and antibody drug conjugates would be expected to reach high concentrations in tumors in the brain, even if they could not penetrate very well into normal brain tissue. The edema fluid that is common around tumors in the brain is very rich in plasma proteins that leaked out there because the blood-brain barrier is disrupted. And if those other plasma proteins can reach high concentrations in and around tumors in the brain, there would be no reason to expect that monoclonal antibodies and antibody drug conjugates would not also be able to reach high concentrations in tumors in the brain. There's also the belief that brain metastases do not respond well to systemic therapies, but this is not supported by the data. Where it's been looked at, the probability of tumor shrinkage or response of brain metastases is very similar to the probability of shrinkage or response and other tumor deposits outside of the brain. There's also a belief that life expectancy for patients with brain metastases is shorter than it is for other patients with metastatic cancers. But again, for lung cancer, for example, we know that patients that only have spread of the cancer within the chest area, that they do better than do patients with spread outside of the chest. But for patients with spread outside of the chest, patients with brain metastases, life expectancy is very, very similar to life expectancy of patients with metastases to the liver, bone, adrenal glands, etc. So radiotherapy may be very useful and important for some patients with brain metastases, particularly if they're large and symptomatic. However, if they're small and asymptomatic, radiotherapy can be delayed or avoided by many patients if effective systemic therapies are available. Overall, the belief that brain metastases should be treated differently than other areas can in some cases lead to suboptimal care. For example, a patient with small asymptomatic brain metastases may undergo radiotherapy to the brain prior to initiation of chemotherapy or other systemic therapies that are urgently needed to treat large tumor areas outside of the brain. So, for example, metastases to the liver or bone or large tumors in the chest. So the delay in the initiation of systemic therapy may potentially be harmful for patients. In addition, because of the belief of the importance of the blood-brain barrier, patients with brain metastases are often excluded from clinical trials. This means that they may not have access to a therapy, an experimental therapy that could help them. It also means that because you've excluded patients with brain metastases, it takes longer to accrue all the patients that you need on the clinical trial to complete it. That delays completion of the trial and delays access to effective new drugs that cannot be approved until those trials are completed. Encouragingly, an increasingly large proportion of medical oncologists are now beginning to understand that the blood-brain barrier may not be as important as we once thought, and that we have to think completely differently about treatment of patients with brain metastases from what we may have thought in the past. Okay, there's also several other myths and legends around cancer that I won't go into right now, but you can read more details in my book, A Short Primer on Why Cancer Still Sucks, that can be purchased online from Amazon Books. I hope that you found this video helpful. Thank you. Bye.